Hello everyone, happy Friday. We are back with more learning. This couple weeks have been pretty crazy, but today we're back with some learning. And based on some of your comments of the couple weeks ago giveaway, some of you guys want to learn about ALS. So today we're going to talk about ALS. So ALS is amyotrophic lateral sclerosis, okay? ALS is a disease that will force us to have a switch of priorities as a physical therapist. As many of you guys know, ALS is a fatal neurodegenerative disease. So people, when they get their diagnosis, we're looking at in between 2 to 5 years of survival after the diagnosis. There are more people that their survival is prolonged based on the care and if they participate in a multidisciplinary clinic. But overall, it's around 2 to 5 years. I have treated some people with ALS back in Kaiser when I was an outpatient, early stage, maybe like a couple months after diagnosis. And I have to say it's a disease that will invite some emotions as you treat and, as you prepare to treat these patients. Because I have to say, in my personal experience, I would experience some emotions, could be sadness, could be, maybe I was feeling like I didn't know what to say. Sometimes that's why I had my mentor with me. It is a challenging diagnosis to treat as a physical therapist because mainly you're there to guide these patients through the disease progression. So we're going to talk a little bit more about it as we go. So ALS is a progressive degeneration of neurons in the spinal cord, the brainstem, and the motor cortex. Okay, the onset is late 50s or early 60s. There are some people that the onset is early, maybe 40s, okay? So it can happen younger than that. The etiology, some people say could be genetic, some people say it's an environmental factor. We don't know. So it spreads to anatomically adjacent regions. And typically, let's say it starts right upper extremity, then it's the left upper extremity, and then right lower extremity, and then left lower extremity, then bulbar, which is brainstem, okay? So it usually starts with the upper extremity, then lower extremity, but this is not like it always starts, usually, but not always. There are some negative prognostic factors if the patient has symptoms that involves respiratory or bulbar muscles, which we'll talk about. They have more of a negative prognosis. So generally, there's muscle weakness that progresses over time, and the pattern and the rate of physical deterioration varies among the individuals, okay? So these patients must cope with functional losses throughout the progression. So they're gonna lose their speech, their swallowing, their mobility, their ability to do ADLs. So they must cope with that. Death is usually because of respiratory failure, okay? So now, we know that ALS, if it's a classical ALS, we're having involvement of upper motor neuron and lower motor neuron, right? And then we also have involvement, maybe bulbar. So here we're just going to review upper motor neuron signs, lower motor neuron signs, bulbar signs, etc. Okay? For upper motor neuron, you'll see spasticity, hyperreflexia, and pathological reflexes. For lower motor neuron, you will see weakness, atrophy, fasciculations, very common, hyporeflexia, hypotonicity, and muscle cramps. Now, something I learned from a neurologist a couple months ago is that fasciculations, you won't really see it. Like, let's say they're dressed and, oh, their hands. No. So if you feel comfortable, you could ask your patient, may I examine your chest and your abdomen? So that's where you will see the fasciculations. So a lot of neurologists do this. They ask them to, let's say, if they're okay taking out their shirt, and then you will see the fasciculations, because you won't see it a lot, when they're wearing clothes or things like that. Not to say you should ask them, but let's say if one time they're saying, sometimes I see those muscles like twitching, like on my stomach or things like that, you can ask them, may I examine you? If it's okay, is it okay for you that I ask if you let me examine you and see those muscle fasciculations, etc. Okay, so that's something to keep in mind. Bulbar signs. So here we're talking about bulbar. When you hear the word bulbar, this just means medulla. Okay, so you're gonna see, you remember your cranial nerves in the medulla. Okay, so just your cranial nerves 9, 10, 11, and 12. So the last 4. Dysarthria, dysphagia, siluria, I don't know if I pronounced that correct, and pseudobulbar palsy. And pseudobulbar palsy is caused by bilateral disturbance of cortical bulbar tracts. So here you'll see dysarthria, dysphagia, facial and tongue weakness, and labile emotional responses, meaning that they have uncontrolled laughing, uncontrolled crying, when in reality, they don't want to cry or they don't want to laugh. So that's your bulbar. Now, respiratory muscle signs and symptoms. You will see that they're going to have trouble breathing at night, exertional dyspnea, accessory muscle breathing, and paradoxical breathing. What is paradoxical breathing? So this is when it causes the chest to contract during inhalation and expand during exhalation. So it's the opposite of how it should be. So paradoxical breathing is like when the regular process of breathing kind of flips, and then you're having abnormal contractions and chest expansion when it shouldn't be expanding. Now we're going to talk about the stages of ALS. So Sinaki and Mulder, I don't know if I'm pronouncing that right, but Sinaki and Mulder, they described in an article that I'm going to show and post in the caption, they were describing 6 stages of ALS. Okay, so this is going to help you kind of identify where your patient is. And this is important because when you prescribe exercise, you really need to know where they are in their disease process. Okay, so first stage 1. So they're independent with mobility and ADLs. Some muscles are weak, and some of them might be just like lack of endurance or minimal weakness overall. Patient really is doing everything that they're used to. PT usually consists of education and telling them about energy conservation techniques, modification of home and workplace environment, psychological support. So the patients are advised to continue their normal activities, maybe do some general active range of motion, strengthening, resisted training, which we're going to talk about a little bit, of the unaffected muscles. Aerobic exercise needs to be submaximal when you prescribe it. So that is stage 1. Stage 2, you're going to see some moderate weakness, foot drop, maybe one or both sides, not very significant, but you can see some some weakness, dorsiflexion weakness, intrinsic muscle weakness, some in the hand, and interferes with handwriting, holding things like that. So here, you where your muscles are weaker, you're going to prescribe your passive range of motion and continue to strengthen some of those muscles that are still unaffected. And remember that heavy resistance training, you don't want to do that, okay? Even if there's stage 1, you don't want to do heavy resistance training. You just want to do your moderate, which we'll talk more about. But here I wanted to emphasize, you should never do heavy resistance training or high intensity exercise with people with ALS, okay? Stage 3, here the patient remains ambulatory, okay, but has severe weakness in some muscle groups, severe foot drop, weak hands, okay, may be unable to stand up from a chair without help. So here's when we introduce like the minimal assistance, they're starting to need some help, stage 3, okay. Mild to moderate limitation in function, okay. The goal is to keep the patient physically independent, okay. Adaptive equipment is needed to support those weak muscles and, decrease the energy expenditure, increase the safety, and maximize mobility, okay. And wheelchair might be a good idea to travel long distances. Stage 4, here you have severe weakness of arms and legs. They use a wheelchair. Passive range of motion is recommended here. Strengthening of the uninvolved muscles is recommended, but here we're looking at more like a light intensity exercise, okay, of those muscles that are unaffected. Here is where you start educating about skin inspections, okay, pressure area, pressure relieves, etc. Okay. Stage 5, progressive weakness, deterioration of function. Lift is necessary to transfer. Pain might become a problem because of the immobility and the weakness, okay? And the pain needs to be addressed. Now, pain needs to be addressed based on the pathology of the pain, okay? Sometimes the pain is caused because of spasticity. Maybe pain is caused because of contractures. Pain may be caused because tightness, I don't know, something like that, okay? So you need to address the pathology of the pain. Patients here might be unable to hold their head up for extended periods of time, so a collar sometimes is recommended. Stage 6, and the last one. Here your patient is bedbound, might be ventilated, or they need help to breathe, okay? Hospital bed should be prescribed, frequent repositioning and skin inspections, okay? Head drop might be a major problem if they do have the head drop, and just progressive respiratory distress will develop. Body positioning is important here, and that is important also because of ventilation perfusion. So really keep in mind positioning and recommending positioning to the families. Respiratory exercises as well as cuff facilitation techniques are helpful, okay, to clear the secretions, because remember, they're weak on their respiratory muscles, so they're not clearing well. So then that secretion gets stuck in their lungs and it becomes pneumonia, okay? So goals for this stage is just mainly like hospice goals. Just address the patients' and caregivers' needs and just maximize quality of life each day, okay? So those are the 6 stages for ALS. Now, exercise prescription.